Good afternoon, everyone. I'm Eduardo Miñambres, intensivist and transplant coordinator in Spain, and I would like to thank the EuroELSO for hosting this webinar about NRP and DCD donation. It's my privilege to share this session with my colleague, Marius Berman from Patwar Hospital. And well, it's quite clear that there is a growing interest in the use of NRP in controlled DCD donation worldwide, because NRP offers much better results in terms of recipient survival than the traditional rapid recovery technique. However, there is still several questions, such as the difficulties of using NRP, or some ethical aspects, such as the possibility to restore brain circulation once death has been declared. For that reasons, we are going to see three different lectures about the intensivist perspective, the surgeon perspective, and the perfusionist perspective. I think that we have three experts that they have a huge experience in DCD donation using NRP, and I think that we will have enough time for questions and debate at the end of this webinar. And as I said you before, it's my privilege to share this session with my colleague, Marius Berman. Marius, the floor is yours.
Thank you very much, Eduardo. My name is Marius Berman. I'm a consultant cardiothoracic transplant surgeon at Patwar, and it is really my great pleasure to introduce my dear colleague and friend, Antonio Rubino, consultant anesthetist also from the Royal Patwar Hospital in Cambridge, UK. And he was instrumental in developing the thoracoabdominal NRP in the east of England. And ever since, he's been in the front line into the interest and trying to progress into the discussion, or aiming to progress into the discussion about NRP, TA-NRP, and overall NRP into DCD. So without further ado, over to you, Antonio. Thank you.
Thank you, Marius. Thank you, Eduardo, and good afternoon, good evening, everyone. It's a pleasure for me to start to kick off with my talk, this great, interesting webinar, and I'll try to give an intensivist point of view. I have no disclosure of interest, no conflict of interest. This is slightly my background, which is mainly I'm cardiac intensivist and anesthetist working at Royal Patwar. And I've been working with transplant patients for a while. But I'm also organ donation lead being in my hospital, and organ donation lead in my region. So in a way, if we can call this a conflict of interest in a way, but it's actually I've been working with donation as well. So seeing what we could say the other side, but I would say is probably the continuum. And actually, I'll try to give this approach and this point of view, this perspective, probably to this topic today. I'll start with a step back, and clearly, if we take for a moment aside the determination of death by somatic criteria, clearly, clinically, we have two. There are legal. There are clearly two ways to diagnose death, or any way we can use, and what we use is the neurological criteria, which is a retrospective way to make it diagnosis, is for a damage which has already occurred, an irreversible damage. But what we are talking today is DCD. So it's actually when we determine death using circulatory criteria, which is more of a perspective of what will happen after a systole, after loss of circulation, which will clearly be an irreversible brain damage again. So it's just to clarify in a way, all human death is actually brain-based, and this is how we should interpret. I'll give a little background, a very little background about DCD generally. I'm a fan of history, and I think is interesting to see how the transplantation has evolved and the donation has evolved throughout the years. The first heart transplant, and this is probably my bias with cardiothoracic organs in this way, looking at the first heart transplant, in theory was a DCD, but just a DCD because actually the criteria for brain death were not issued. So the criteria were issued 1 year later in Harvard. And since then, clearly, transplantation overall for decades has always been in DBD. So DCD has been forgotten for a long while, until probably the 90s, when, thanks to the kidney transplantation, actually to the abdominal transplantation, clearly DCD has become, the DCD donation and DCD transplantation has become more of a reality. And we all recall the first DCD heart transplant from almost already 10 years, it's 8 years ago in Australia and then UK, the first DCD heart transplant, which have actually made a huge impact in increasing, this is the UK experience, increasing the pool of transplantation of more than 24% overall. This is a snapshot of the UK reality, or the UK let's say donation rather than transplantation, and is the deceased organ donation, in the way to say clearly this is reproducible also in other countries. Clearly, all the countries have put together strategies to try to increase the pool of donation, to try to increase the transplantations numbers, clearly. And if there's been a marginal increase, a steady, regular increase in DBD donation, the real progress has been in DCD, because the DCD numbers, the donations from DCD donors, have almost tripled in the last probably 10 to 12 years overall. But in DCD donation, we know there are challenges, and the challenges are especially related to uncertainty of donor outcomes. In UK, we have 30 to 40% of consented and matched donors, which are not proceeding. So it's what we call prolonged time of asystole. So donations which doesn't go ahead, which means not just mobilization of team and utilization of resources, but also imagine the family experience and the rather emotional experience for those families overall. But there is another challenge clearly with DCD donation, and the other challenge is the warm ischemia, the hypotension, the prolonged hypotension for 30, 40 minutes, more than happens to organs, and the damage that this could cause. And this is why then when we talk about DCD donation, there is also always we need to go through a prompt determination of death. We need to have a ready transfer to theaters, from ICU to theaters, and however it is the logistic of our hospital or different hospital in different country is. But we need to be ready, and sometimes what happens since the determination of death, the declaration of death to organ retrieval, is as quick, as quick, as efficient as it would be in any other emergency C-section or a ruptured AAA overall. What can we do to make these marginal organs better, these organs that had these challenges of deep hypotension for a while? Well, we know that there is an ex situ organ perfusion, organ recovery overall, is not just for hearts and clearly for livers and the fridges where we keep the kidneys and the lungs clearly. But this is, and looking at the future, there is discussion about clearly having these recovery centers for organs, where organs can be assessed and can be clearly optimized and stored. But this is the future, and we know this future has some cost within it. But we're here to talk about NRP clearly, because what we have now is normothermic regional perfusion, is what we can reperfuse the organs, we can reduce the damage of warm ischemia, which I was mentioning before. And again, is proven. I'm not the best person placed here clearly in this talk to show the good outcome, but we have seen that actually the outcome with DCD organs with NRP are comparable. A lot of studies have had comparable results with DBD organs. So outcomes from NRP, DCD organs, pretty similar to DBD organs overall. And this has been seen for abdominal organs, it's been seen for cardiothoracic organs, for heart as well. So same results of TANRP of DCD heart recovered, similar to DBD as well. But let's stop for a minute, because we said about ethical challenges, and actually the first challenge is possibly about how we define death And in these days, it's not that obvious. Clearly, with all the mechanical supports, mechanical devices that we have, we are not probably looking anymore at the asystole. So we can have alive patients on VF, or clearly on asystole with mechanical devices. But this one it does apply also to the clearly the retrieval in the transplantation side. In a way, we need to remember what is the death donor principle, which might sound obvious, but clearly what we need to recognize the death is a process. Actually, dying is a process, and the death is the final point of that process. And we should not interfere with this process. And not interfering means that we should not declare death, we should not facilitate death because of organ retrieval or because of facilitating clearly donation in a way. And means if we're saying that dying is a process and death is the final process, is this final end of this process, means that this process should be permanent and should be actually irreversible. And we shouldn't interfere with this process during this process, and we shouldn't interfere after this process as well. So any post-mortem intervention should not be restore what we say is cerebral perfusion overall. So then the ethical question, which is actually, are NRP programs ethical, and why are not, and why there have been challenges to NRP programs overall? Well, the challenges has been for abdominal NRP, probably because of the challenges or doubts whether there have been inadequate occlusion on the descending aorta, which could have allowed cerebral perfusion. I think the challenge is especially for the TA NRP in a way, because of a closer clearly anatomy to the aortic vessels and because of the possible collateral which could still perfuse the brain. And if we look at the anatomy might seem straightforward, but it's actually quite challenging to see how the collateral from the aorta could possibly perfuse the brain stem overall. And in a way, the abdominal NRP has overcome this ethical challenge much earlier, probably. I wouldn't say better, but has overcome these ethical issues because it's been proven with a adjusted technique, with different technique and surgical technique, which will say that actually the pressure in the aorta, in the ascending aorta during NRP doesn't change, or is actually minimal overall, which would not allow any perfusion. So and the same principle has been proposed, probably, or similar principle technical principle has been proposed for the TNRP in the way of drain the brain or try clearly not to perfuse at all the brain. But the ethical challenge is there, and the ethical challenge is not just in the medical society. Has gone out. There is a white paper from an eminent ethical American group, which has, and the discussion has moved also in not strictly medical journals as well, with actually raising the point whether this could be ethical or not. And clearly, what is the medical society is trying to do, what we are trying to do, we are trying to clearly, with research, to actually demonstrate that, yes, what the NRP is safe and the NRP might be safe. So what we have so far is case series, and this is the way we are proving in a way that we can exclude cerebral perfusion. And this is what we are also trying to do. We'll hopefully start soon in Cambridge, actually try to confirm that there is exclusion of cerebral blood perfusion. Just to conclude, so the question is actually whether it is ethical to exclude brain circulation and whether we can exclude cerebral brain circulation. The answer probably is yes, if we accept the brain definition of death. If we accept if our definition of death is brain death, and it is challenging. It's challenging already. The definition of death is not surprising to think that, I wouldn't say varies between countries, but there is not a unified definition of death overall. It's clearly problematic if the definition of death is not brain-based. And again, just to conclude with few observation and on TNRP, clearly, one of the challenges, and generally is not just applied to TNRP, but generally, is difficult to understand or to define what is meaningful blood flow, minimal blood flow. We can't really differentiate between whether there is cerebral blood flow, whether that cerebral blood flow is enough actually to perfuse the tissues, is enough actually to restore cerebral function in a way. And this is possibly the difficulties. And so far, we've not been able to 100% exclude there is no or there isn't or there is no cerebral blood flow overall. And the studies, the case series which are growing evidence, these are probably moving towards this direction overall. Also, the technical, the NRP, TNRP is technically challenges. So we are adding clearly challenges to the surgeon in a way. And clearly we said we reperfuse organs, but in a way, increasing technical challenge means also increasing the warm ischemic time in a way. So these are all challenges which I hope today, which I hope in 10 minutes I probably brought up. I hope we'll follow with more discussions. Thank you very much.
Thank you very much, Antonio. Brilliant, as always, brilliant. I can't see any questions on the chat. Christian, are any questions from your side?
Marius, maybe it's better to have the 3 lectures and the end.
Okay, yeah,
we have 30 minutes for a whole debate and questions for the 3 speakers at the same time.
Okay, let's do that.
Maybe it's better. And we have time for thinking about potential questions.
Okay, perfect. Sounds good. Are you happy to introduce the next speaker, Eduardo?
Well, it's my pleasure to introduce my colleague, Constantino Fondevila. He is a transplant surgeon in Madrid, in the University Hospital La Paz. He is the head of the general surgery service, and he has a huge experience in the use of NRP in liver transplantation. He has worked several years in Barcelona, and now he is leading this program in Madrid. Constantino, you have the floor, and thank you for coming and accepting this talk.
Thank you very much, Eduardo, and all of you for your kind invitation to participate in this webinar. Let me see. So I'm going to talk about the surgeon perspective, applying NRP in DCDs. So as you know, the classification of DCDs is shown in this table. So when we started DCDs in Spain, we started working with category 2 and controlled DCDs. Those donors that suffer an unexpected and irreversible cardiac arrest, usually outside the hospital. So in this setting, using the one that we developed, the NRP, to be able to procure good quality organs from the abdomen to be transplanted. But the category 3, the control ones, are the ones that are more widely used, not only in Spain, also in the rest of the world, in Europe, US, etc. And we have now in some countries an additional category 5, which is also controlled DCDs, and are the ones that suffer the cardiac arrest following the euthanasia. So the problems with uncontrolled ones that I am going to focus a little bit during my talk in these ones, but I think they are very interesting ones, and the ones that may allow us to get more organs to be transplanted, because they have a huge potential. But the problem with them is that these donors typically suffer an important warm ischemia time that you see here. Since a cardiac arrest happens, there is no CPR, then CPR starts, but there is a low flow usually, and then the non-touch period to have death declaration, 5 more minutes. And then since arrest to the start of preservation maneuvers like NRP, it takes quite prolonged timing, up to 150 minutes in our initial setting. So uncontrolled DCD donor preservation, we show how among the different techniques that were used, NRP was the one that was showing the better results, better immediate function, and was the technique of choice for the preservation of abdominal organs. And we showed this in the lab and in different studies that we perform. So once we start NRP, we have this, after that, we have full flow reperfusion, but then we have the cold ischemia time once the organs have been procured. And during transplantation, we have an additional period of warm ischemia during the vascular anastomosis, and then we have the reperfusion with, again, full flow to the abdominal organs. But it's a long process that needs to be adequately managed, and it is not simple logistically, especially when applying NRP to improve the quality of these organs. So I'm sure you have seen this picture in before. I showed this picture that was taken in the workshop that we performed in Barcelona in 2016 when we had the international DCD meeting. So you see the aspect of the liver and the intestines after 30 minutes of cardiac arrest, and how by just 30 minutes of NRP, the aspect of these organs, abdominal organs, importantly change. They recover the normal blood flow, and we show how they decrease the antioxidants, they improve the ATP, the energy substrate. So many important physiological explanation, because it is able to transform the initial cardiac arrest into a period of ischemic reconditioning. So we are able, by doing this, and we have a lot of science behind showing how it's not only the aspect, but also a lot of physiological things that are going on in these organs during NRP. So how we do it in the clinical setting, we place the cannulas in the inguinal area, the femoral vessels, arterial and vein, and we in the contralateral groin area, we place the Fogarty balloon, and then we are able to start NRP. So we develop in uncontrolled DCD setting again, but we have been using this criteria also for controlled DCDs, the liver selection criteria. Depends, the timing is very important, also the donor categories, and also the method. I don't have time to go deeply through this table, but you see how during NRP is very important to evaluate different parameters that will help us to decide if the organ is going to be transplanted or not. And during the organ recovery also, we can see different aspects, evaluating the macroscopic aspect of the organ that will help the surgeon to decide if that particular organ is going to be transplanted or not. But even though doing this, in this meta-analysis, it was shown how NRP in uncontrolled DCD versus the regular donors of livers from donors after brain death, they are still marginal ones. And we have still an impact, even using NRP, in terms of graft and patient survival, which is worse than in the regular DVD. So still a lot of room for improvement in the setting of uncontrolled DCD. But this helped us to learn a lot of things that we were able then to implement in the setting of controlled DCDs. In Spain, it was a pilot study in 2009, and then in 2012, after ONT established the national regulations were adopted, we were able, on consensus conference and so on, we were able to start in the whole country abdominal NRP and organ procurement from controlled DCD. So in controlled DCD, you have the advantage that if the ethical committee in your institution or in your country allows you to perform the cannulation before the withdrawal of the ventilatory support, you gain time. You decrease warm ischemia for those organs. If you cannot do that, it's not essential. You can do it after death. It's been declared. And then you always start NRP after death is declared. So how can we do it? Pre-mortem cannulation, we can do it, as you see in these pictures, with the Seldinger technique, and we place the cannulas. Then we check where is the Fogarty balloon or the occlusion balloon in the aorta located before inflating the balloon and before starting the NRP. You see this picture showing with the location, and once the balloon is inflated, we always do again the chest X-ray exam to show that and to be able to know where is the place. In countries like you cannot do premortem cannulation, and this happens, for example, in Italy, in France, they place wide wire cannulas. They don't cannulate, but we place the wide wires, only to be able to cannulate faster once death is declared. So it's another option. And another option, like in the UK and the Netherlands, you can cannulate after opening the abdominal cavity directly in the aorta and the IVC. So you can have different techniques depending on the place you work and the regulations that you have in your country. In Spain, what has happened in controlled DCD is that NRP has been expanded importantly over the years. This is slides until 2019, and super rapid recovery is now completely gone. You see how it was until 2016, 2017, half and half. The surgical teams choose to do super rapid or NRP, but right now, many, I would say 95% of the places are using, or the teams, even the hospital has transplant or not, and is far away from the transplant hospital, all of them are doing with mobile devices or normothermic regional perfusion. So it's feasible, and this picture shows that the evolution. So some logistical aspects and technical aspects. This was published in 2021 by Ina Jogmans and the group of the working group of ESO-TLJ. The duration of NRP in DCD is 1 to 4 hours. Parameters to evaluate, obviously temperature and flow continuously, gasometric and other perfusate parameters, AST, hemoglobin, and at least once every hour. Every half an hour is better from my point of view. So additives to perfusate, there is discussion of this, but obviously essentially red blood cells to maintain adequate hemoglobin levels and oxygen delivery, and heparin to maintain therapeutic ACT. The liver evaluation, obviously we need to evaluate the biochemical parameters in perfusate, transaminases, lactate, simple things. So bile production and quality, some groups are working on this. It's not clear evidence, but you can do that if you can rate the bile duct. Macro and microscopic findings, if the liver has some degree of steatosis, fibrosis, and so on. Kidney evaluation, the urine production, and macro and microscopic findings also during the kidney procurement. And for the pancreas, also some biochemical parameters in the perfusate. The AST, ALT are also useful. You can check amylase to see the injury in the pancreas, and the macroscopic aspect, especially for the pancreas, is also very, very important. So by doing this in the Spanish experience, published in 2022, with enough follow-up for liver transplanted until December 2019, NRP show improvement in terms of recipient survival and graft survival, as you can see in these pictures. Other countries have been following, and not only Spain, but also France, Italy, Netherlands, the UK. You see they have shown also results from cohort studies evaluated abdominal NRP in controlled DCD liver transplantation, and you see how survival is extremely good. ITBL, which is the more feared complications, because in those livers may end up requiring a transplantation. Otherwise, the recipient is in serious condition or has serious problems with ITBL cholangitis and continuous infections and many problems. So this is, you see the rates of ITBL while using abdominal NRP in this setting is really low, and this is also comparable, even lower than the results obtained, for example, in the Netherlands that have been recently published in Annals of Surgery 2022, which is 7%, and we can even improve these outcomes in controlled DCD by using abdominal NRP, even when we use quite older donors, even in their 60s or 70s, and with quite high donor warm ischemia time. So when we try to evaluate which were then the characteristics that impact in the outcomes, we saw that are not directly related with the quality of the organ, because these are the two independent prognostic factors for graft survival were cold ischemia time and the need of longer than 7 hours, and bad recipients that need retransplantations. Those two conditions impact in our cohort, but again, by selecting better the recipient and trying to reduce as much cold ischemia time, or now improving excite to machine perfusion like HOPE or dual hypothermic perfusion, you might decrease the impact of cold ischemia time in this setting. So using not only abdominal NRP, but also excite to machine perfusion, you can decrease the impact of cold ischemia time. So is there a room for improvement? Yes, there is a room for improvement, and this technique is evolving over time. So from the initial picture in 2007, for this we have recently published, you see how we can avoid the use of the heat exchanger. Why not? We can avoid the use of the reservoir, and we can try to find improvements in the technique that may even help us more to improve the quality of those organs, abdominal organs. There is a lot of discussion about the perfusate we are using. I talked before about the statements from the TLJ, the minimum requirement crystalloid, enough crystalloid to fill the circuit tubing, but you see that different countries are using different strategies, using different priming solution and adding different things, and also additives. You can see here there are different possibilities, but at least the essential is the red blood cells to maintain adequate hemoglobin levels and oxygen delivery and heparin, as I mentioned before. So for the future, what considerations for in situ perfusion? First, why not subnormothermic initial temperature? I am sure the intensivists in the room can help us to show why this may be beneficial in this setting. So the initial mild acidosis, why not to try to keep it like this and not adding buffer in the priming solution? Different studies resuscitating patients and improving the situation of the brain in this setting has shown why not to keep transitory acidosis may be also beneficial. The control of ion concentration, why not? In this setting, some people is also advocating maybe for introducing a hemodialyzer during NRP. And why not pulsative flow to be more physiological instead of continuous flow in the setting? So my final comments. So NRP has helped us a lot to be able to transplant organs from DCDs, and in many countries now it's the standard of care, like in France, Spain, and many others, Norway. So this is a standard in controlled DCD and in uncontrolled DCD in Spain. In uncontrolled DCD has helped us to set the stage and to see what needs to be done. We have learned a lot, and we have a lot of potential room for improvement in uncontrolled DCD. We don't have to forget about this. So in controlled DCDs, ante-mortem cannulation, if possible, in groin, or post-mortem cannulation in groin or abdomen, depending on the setting. it allows us to recondition not only liver on pancreas and kidneys, multiple organs, and now also in the chest. And we have also the potentiality to be improved to recover more marginal controlled DCD and especially uncontrolled DCD livers. So let me show you this slide to remind you that we have the LITA summit in April 2024 in Spain, where we will be discussing about liver discard and viability assessment, also through NRP. So I would like to invite all of you in the audience that are interested in the topic to attend the meeting. I think it will be a very important one. And also we have the abstract submission open. So in case you are working in the field, you are we are more than happy to receive your abstracts for the meeting. Thank you very much for your attention.
Thank you very much, Dr. Fondevila. Very, very interesting. Thank you so much. As we discussed earlier on, we will take all the questions at the end. And it's my great pleasure to introduce the last speaker of the, last but not the least, of course, is Miss Marta Velia Antonini, ECMO specialist in Romania. And she's the chair of the EuroELSO NRP working group. So Velia has a huge amount of expertise, so looking forward for sharing your thoughts. Thank you very much. Sorry, Marta, I think you're on mute.
Hey, are you able to hear me?
Yeah.
Okay, perfect.
Perfect.
Thank you for the introduction. And I'm going to focus mostly on the technical aspect of NRP in DCD donors. So I have now a conflict of interest. As you heard from previous presentation, we need an extracorporeal support in DCD donors mostly, and we need cannulation to provide this extracorporeal support, and but we also need to provide occlusion to prevent cerebral reperfusion during NRP. There are different techniques to implement this kind of extracorporeal support. It could be a peripheral cannulation, it could be a central cannulation, and the access to the vessel could be percutaneous, could be surgical, or could be hybrid with a cut-down technique. Most of the time, NRP, at least for abdominal NRP, is provided through a femoral approach, really similar to the one that we use for VA ECMO. About the aortic occlusion, again, there are different strategies and different techniques that could be used. It could be an endovascular occlusion for abdominal NRP. It could be an aortic cross-clamping. Obviously, an aortic cross-clamping requires a thoracotomy to be implemented. And for a thorac-abdominal NRP, it's a slightly different situation because you need to clamp or to ligate the neck vessels before proceeding with NRP to prevent any kind of cerebral reperfusion. This is a different technique that could be used if you mostly have difficult access to both the femoral vessel. You could use one single cannula to provide arterial return for the blood, and also an access to inserted balloons to provide the endovascular balloon occlusion. This strategy, it's costly compared to the conventional one, but is definitely effective in patients with difficult arterial access. This is a conventional configuration for abdominal NRP. You could see the peripheral vessel in the femoral and in the artery and in the femoral vein with the aortic balloon occlusion. This could be good for abdominal NRP. Normally, when you need to recover also the lungs, you need to put the drainage cannula a little bit slower because it could be difficult during lung recovery if you have a really high drainage cannula, and also you risk air entrance inside the system if you are really close to the right atrium. So this could be a really good strategy for abdominal NRP, also for recovering the lungs. About the circuit, you have seen this image before during the talks. This is one of the first circuit that has been reported to be used during NRP. And now we use different kind of circuit, easy circuits, mostly derived from ECMO support. We now have on the market also circuit thing to provide NRP, short-time circuit, really easy to be prepared, and also really inexpensive compared to conventional ECMO systems. You hear about this consensus paper by EuroELSO published at the end of 2021 in the in this consensus paper. It has been told that a basic circuit for providing NRP should include at least a centrifugal pump, a membran lung, and an ITER unit, because at the time, to date, we still provide a normothermic regional perfusion. In the future, who knows, probably we could consider a subnormothermic regional perfusion, but at the moment, we still use ITER unit during NRP, at least in most of the centers. This is a circuit that could be used for abdominal NRP if you want to recover the heart. So if you want to go for thorac-abdominal normothermic regional perfusion, normally you need something else. A different kind of circuits could be used for thorac-abdominal NRP. You could use a conventional cardiopulmonary bypass circuit. You could use an hybrid circuit, meaning something easier compared to cardiopulmonary bypass, something similar to the ECMO circuit, so a mobile circuit, but including a venous reservoir that could be really useful during heart recovery in DCD donors. But some centers are also using a conventional ECMO system, so a completely closed ECMO system without any kind of reservoir, even if some kind of modification needs to be performed in order to be able to vent, for example, the left ventricle, and to provide the recirculation when the heart is able to provide cardiac output. So when you are able to wean completely the donor from the NRP during the run. No matter the kind of cannulation that you use, no matter the kind of the position of the aortic balloon that you consider optimal in your donor, but you need to assess the position of the cannula and the position of the balloon, because a proper NRP runs is strictly connected with the proper position of the cannula, particularly of the drainage cannula, and the proper position of the aortic balloon. It's really important to prevent any kind of cerebral reperfusion. You could check with the chest X-ray as usual, but you could also use transesophageal ultrasound. In my center, we mostly use transesophageal ultrasound to assist cannulation in DCD donors, but also to assist the balloon positioning. And differently, if you use a transesophageal ultrasound and not chest X-ray, you could also check the perfect closure of the aorta. So you're able to assess not only the position of the aortic balloon, but also if you have any kind of leakage of blood during reperfusion. This could be really important, not only for ethical reasons, but also because if you have a leakage, you have a mostly ineffective flow during reperfusion. So it's important not only to check the position, but also to check if you have a complete occlusion of the aorta or not. Because you could have a perfect cannulation, you could have a perfect balloon positioning, but you could still have a complication during the run. So you need data, you need to monitor the donor, you need to monitor the perfusion, you need to monitor the organ during NRP to be able to understand that your perfusion is effective. About the donor, we check the peripheral perfusion. A basic monitoring is looking at the donor the whole time and check for the skin. You are supposed to have, for abdominal perfusion, a cold, mottled upper body and a really well perfused lower body. We continuous monitoring the ECG during the whole run, because sometimes if you have any leakage from the balloon, you could have a reperfusion of the coronary arteries with warm oxygenated blood, and you could have some kind of QRS complexes, and this could precede a mechanical contraction of the heart. And if you have any kind of ejection from the left ventricle, you could have a cerebral reperfusion, and we do not want this kind of reperfusion for ethical and legal reasons. We also check the pressure during the run above the endovascular balloon occluder and below the endovascular balloon occluder for abdominal NRP. For thorac-abdominal NRP and for lung recovery, we also check the airway pressures, and we also check the pulmonary pressure with an advanced hemodynamic monitoring, mostly through Swan-Ganz catheter. And we also want to assess neurological, eventual for a neurological monitoring in the donor during thorac-abdominal NRP. We mostly use regional oxygen saturation, so regional oximetry through NIRS infrared spectroscopy, and we also use this near-infrared spectroscopy not only to as a neuromonitoring tool, but also to assess the regional saturation of this splanchnic organ during NRP, during abdominal NRP. About reperfusion, we check the extracorporeal blood flow, the fresh gas flow, and the fraction of oxygen to the membran lung, and eventual complication. The most common complication of NRP is definitely what we call drainage insufficiency or access insufficiency, so the inability to provide the flow, the target flow that we want in our donor. About the blood, we check hemoglobin and hematocrit, we check the arterial blood gas at least every 30 minutes. In some sensor, they check every 60 minutes. For thoracoabdominal NRP, when we want to retrieve the heart, we check the arterial blood gas analysis every 15 minutes. We also check biochemistry and coagulation. There is no consensus about the level of anticoagulation that you need to provide during NRP, but most of the centers report at least 300 seconds of ACT for abdominal NRP and for a thoracoabdominal NRP with a closed system. And obviously, if you want to go for CPB during thoracoabdominal NRP, you need to use the conventional 480 seconds of ACT. Again, we also check the temperature of the blood, aiming to normothermia. About the organs, we have listened to Constantino in the previous talk. We check macroscopically and microscopically the organs, but we do not perform biopsy for all the organs. And we also assess the function. Obviously, it's easier for the lungs and the heart to assess the function. For abdominal organs, you need to rely on lab data. About the target of our NRP, there is no consensus at the moment about the flow. Flows from 1.7 to 4 liters per minute have been reported for abdominal NRP. At the beginning, it was 1.7 liters per square meter of body surface area. Then other groups started using 1.7 as an absolute value, which maybe it's a bit low, and flows up to 6 liters per minute have been reported for thoracoabdominal NRP. With my group, we started using 60% of the cardiac index that you should have in normothermia for abdominal NRP and 80% of the cardiac index for thoracoabdominal NRP based on calculation derived from cardiac surgery. And we are able to assess that with this kind of flow, we are able to provide the same flow in the celiac trunk during reperfusion that we have before the death. So we are able to achieve the same flow that we have in the donor before declaration of death. About the pressure, this could be an ideal mean arterial pressure to be achieved during NRP is not always feasible. Mostly we have slightly lower pressure because of massive vasoplasia that you could have in the donor, particularly if you have prolonged ischemia time, and we in Italy have really prolonged warm ischemia time. We also monitor the perfusion in the territory that we are not perfusing, because if you have an increase in the perfusion of this territory, it could be an early sign of a leakage from the balloon. So we persist in monitor both the pressure above and below the balloon. This is the ECG. We look at for an asystolic ECG. For the wall reperfusion, we do not want to see any kind of QRS, because otherwise you could have also a mechanical activity. No matter the flow that you are able to achieve, no matter the pressure, sometimes you are not able, particularly for prolonged NRP, to achieve the target blood flow that you aim for. We check lactate, and if lactates are decreasing, probably your abdominal reperfusion or your thoracoabdominal reperfusion is good. So we do not want to administer vasopressors to provide cosmetic high mean arterial pressure. We want the decrease in lactate for us to be sure that our perfusion is effective. This is one of the advanced monitoring that we perform in our donors. For example, this is the flow in the celiac trunk during reperfusion. And again, with the 60% of the predicted cardiac index in abdominal NRP, we are able to achieve the same flow that you have before declaration of death. This is another kind of advanced monitoring that we started using in our donors. This is the regional saturation through NIRS at the renal level. You could see the basic level of regional saturation for the left and for the right kidneys, that you have a decrease a really deep decrease in the regional saturation during the declaration of death, so during the no touch time. Then when you start reperfusion, if you are able to achieve a proper flow, you are able to increase the regional saturation level at the suprabasal level. Then at the end of reperfusion, when you induce the cold static storage, you see this decrease in regional saturation, but due to this cold static storage, you are able to decrease quickly the oxygen demand of the organs, so you do not have the saturation so deep as for unprotected warm ischemia time. And sometimes the problem with this technique is that you should have the kidney not too deep, because you have some limitation in this kind of measurement if you have the kidneys below 3 centimeters. So sometimes we use not only the renal regional oxygen saturation, but also the liver regional oxygen saturation. Obviously, you have different kind of values because of the different extraction and the different perfusion of this kind of organs. You could see here, we saw this really deep decrease in regional saturation during the warm ischemia time. When we started perfusion, we were not able to achieve a suprabasal level of regional perfusion. We administer red blood cells, and we were able to achieve a proper flow. So with this kind of advanced monitoring, you are able to assess the quality of your reperfusion, and you are able to assess your oxygen delivery during the whole reperfusion. About the target that we use for arterial blood gas analysis, we aim not to provide hyperoxemia. It's really easy with the modern ECMO circuit to have hyperoxemia, so we try to be really careful. We aim to be normocapnic, and we aim to premembral lung, so to a venous saturation between 60 and 70%. But again, always remember that oxygen delivery is not only about saturation and about the flow, but it's also about hemoglobin, and we try to keep hemoglobin always above 80 grams per deciliter. And with this kind of advanced monitoring, we hope to improve our technique together with the increased number of donors that we are performing in our country, and together with the additional data that we have from other countries. And we hope that with this advanced in normothermic regional perfusion, we could be able to increase this ratio between potential donor and utilized donor in the future. And it's all by my side.
Thank you very much, Marta. I mean, fantastic talk, very clear, very one of the best that I heard about the NRP circuit. So all the talks fantastic. The 3 talks, I will briefly address the elephant in the room, the TA-NRP. By no means it's not a discussion about this, because otherwise we'll be here till next week. There's a lot of data. Antonio touched on that. There is a trial in UK that Antonio is leading. There's another trial using CT as well in Belgium, and obviously there is a paper of my co-chair recently from AJT where, well, Eduardo, you probably will explain better than me what they show, but it's very promising results about TNRP, and hopefully in 2024 the debate will be solved to everyone's satisfaction. There's no doubt the NRP is a fantastic way to preserve DCD organs. TNRP has been shown in multi-organ very good outcomes for abdominal organs, for lung organs. I think the last 2 comments, it's important the work that Marta is leading from EuroELSO about the NRP registry, and we're planning also for ESO-TECTA to join this registry to make it clear. We have slightly different definition in European and North American literature. When in Europe, when we say NRP, we mean ANRP, and TNRP, well, it's TNRP, and North America NRP is everything. It's essentially TNRP because they don't do many TNRP. I'm aware of time, so over to you, Eduardo. And there are a few questions, if the colleagues are happy to look at the questions as well, the very specific questions in the chat.
Yeah. Well, we can read some questions. First of all, it was solved. Stewart Yassin, he asked about the maximum time of ECMO once it's cannulated, 4 hours, as Constantino Fondevila told us. And there is a question, I think, for you, Constantino. Has pulsatil flow shown benefits in NRP, as you said? Is it recommended? What's your experience about that? Because with the ECMO, we have constant flow, no pulsatil flow.
Well, I don't have any experience with pulsatil flow, but it is mentioned as one possibility to improve the perfusion, maybe being more physiological. And but I don't know. I think it's an area of research. I don't know if Velia has experience or know if someone has experience with pulsatil flow in this setting. We don't have. It was just mentioned as a potential area of research and improvement.
I think we have an experience of those levers obtained with thoracoabdominal NRP. I have only the experience of 8 cases in which livers were obtained after thoracoabdominal NRP for heart retrieval. In our experience, the results were quite promising. And I think it's a way to evaluate the pulsatil flow, because these livers are perfused with the heart pumping by itself. I think, Marius, that it will be a great possibility. I think the experience worldwide with livers obtained with thoracoabdominal NRP are excellent. Yep. But maybe now we are selecting an excellent donors, because up to now, the thoracoabdominal NRP donors are excellent donors, younger than those obtained with abdominal NRP, I think.
Yep. I see, Mateus.
I can say, if I may, yep. In the Excite2 liver perfusion, it's been a lot of debate, and some of the machines, to be short, some of the machines that are now in the market are using pulsatil flow instead in the artery through the hepatic artery perfusion. Like, for example, the group of the ex vivo machine is using pulsatil flow. Some others are using continuous flow, and there is still debate of which is best when talking about Excite2, not about in situ regional perfusion. Sorry.
There are two. Sorry.
No. For mechanical circulatory support, it still needs to be demonstrated that the continuous flow, particularly for short time, is dangerous for the organ. So probably it's safe. And as Eduardo says, for a thoracoabdominal NRP, we are able to provide pulsatil flow by the native heart. And these kind of donors are really good donors because you create a sort of DBD-like donor without the damage of the autonomic storm, particularly on the heart. So are definitely really good donors.
Yeah. Mm-hmm. So can I touch on that? Mateus, I see Antonio is typing vigorously a long answer. So I leave it to him about how to set up a DCD. Suresh, 2 questions. Yes, there is a start. There is increasing data about lungs with TNRP. There's an excellent paper from Cedar Sinai, Pedro Catarino, summarizing initial data from the States. There's no doubt that it's a start. We need to reintubate and ventilate. There are certain parameters that you should aim, but it's starting the data starting to suggest that by certain anesthetic manipulation, you can achieve good outcomes with the lungs. Regarding TNRP, how long? Well, the idea is to assess the heart, as Marta suggested. When we did the TNRPs, we were aiming for less than 60 minutes. Within less than 60 minutes, normally the heart usually started beating within minutes, and then we gave it 30 to 45 minutes time for energy, ATP storage replenishment, and then we were weaning the NRP, hoping for the heart to take over, and then assessing the function of the heart with TOE and the Swan guns. And if the heart was not picking up, then we were just simply going back into the NRP. That was the question for Derek.
One of the more our surprises when we started to obtain lungs with thoracoabdominal NRP, we have short experience, but we have done several cases up to now, is that we thought that ex vivo lung perfusion was needed because of the lung edema provided by the thoracoabdominal NRP. But in all initial cases, we have never used ex vivo lung perfusion because the lung grafts were excellent. I have to say that in these initial cases, we have also used very young donors. But we thought that there will be a lot of lung edema using thoracoabdominal NRP, but that's false. We didn't observe this lung edema. And this is one question for all of you, is about the challenge to combine several surgeons at the same time. When we are retrieving livers, the liver surgeon are focused on the liver. The heart surgeon is focused on the heart. But here in DCD, we have to combine all our efforts. When we clamp the cava vein to retrieve the lungs, we can drop the pump flow, for example, or if the heart is not recovered with thoracoabdominal NRP, we could have some problems for the livers. I would like to tell any of you, how is the experience to work together in different grafts at the same times with heart, lungs, or liver? Because this is one of the most challenge to the simultaneous retrieval of different grafts in the thoracic cavity or in the abdominal cavity.
So if I can chip in, there's no doubt, I fully agree with you, Eduardo, working together is the key. So everybody has to accept that when abdominal or cardiothoracic are attending a retrieval, the goal is to retrieve 5 organs, no less. It's not our organs or their organs. And there's no doubt in UK, there has been a huge progress in communication, working together and sitting together and then creating the protocols, particularly if we do like we do currently in France and UK, we do abdominal NRP and simultaneous retrieval of cardiothoracic organs. These are very challenging retrievals, and working together with a good handover and good communication is the key for success. And we've seen the cases where it worked well and the cases we didn't work well, but usually it's the lack of good communication.
I agree with you totally. I think this is the great challenge.
And another challenge is if during thoracoabdominal NRP, you understand that the heart is not recovering, you need to save the abdominal organs. So you need to move to a conventional abdominal NRP, not to lose not only the heart, but also the abdominal organs. So you need to be strict on the criteria that you consider and on the time that you consider safe to try to recover the heart, and then eventually move to conventional abdominal NRP.
There's a question
I would say that it is a challenge. It is difficult. We all have the experience of some organ procurements that did not go as we expected in the beginning. So we have learned a lot. And to me, what I think it is key is to have all the procedure standardized, so everybody knows what needs to be done. And in case there is an issue, everybody knows how to solve the potential difficult situation to avoid damaging one of the organs. So that is key. If you want to start this process, to have everything clear, everything standardized for all the liberty of the surgical teams, the perfusionists, and so on. So learn from others if you want to start and try to go from there. Yeah.
Antonio, a question from Ivan regarding sedation after withdrawal. What is your position?
Sorry?
There's a question from Ivan Martin about use of sedation after withdrawal of supporting maneuvers.
Antonio, for you.
Just briefly, I mean, I was sorry, I was also typing another question, which I might probably answer straight away. I think the sedation, this is challenging again in the way there's always a different practice overall in what we do. If we're talking about DCD, clearly there is all the infusion for sedations are discontinued at the time of the declaration of death anyway, in this perspective. So there is no sedation after that. So we need to be confident, we need to be sure we are certifying death at that time. So there is no real need for sedation. I think the challenges are more in DBD and probably the ethical challenges in terms of sedation afterwards. If I might just answer a quick question overall, there was a question regarding how can we make sure in the ANRP there is no collateral as well and there is no flow overall. I think and probably Eduardo can touch as well on this, Eduardo and Constantino, what we call the Manara technique. Alex Manara is the great intensivist I've been lucky to work with, and great expert on this as well, which actually showed that a large bore cannula in the ascending as open to air has showed that there is no increase in pressure. There's a minimal pressure of probably 2 or 3 millimeters of mercury or even less. And I think if I can say, probably in the ANRP, as I said before, we don't have 100% certainty, probably in neither of the technique, but ANRP has made more step forward. We are more confident that we are with the ANRP, and probably this is where we need to get with the ANRP overall.
Well, in my view, one of the great ethical problems today is the possibility to restore brain circulation. As you said, Antonio, in the case of abdominal NRP, we are sure that there is minimum flow. We have the experience of thousands of cases with abdominal NRP, and we haven't seen any problems. We can check the pressure in the left radial artery, and there is no pressure during abdominal NRP. But in the case of thoracoabdominal NRP, we have changed our minds. At the beginning, the initial experience of the UK, you started to clamp the supraortic vessels, but we realized that there is the potential of collateral circulation throughout the head. Now we have published our experience. We have placed a sensor catheter in the circuit at Willis, and we have observed that the pressure in the circuit at Willis, once death has been declared during the 5 minutes of non-touch period, this pressure is constant during the whole procedure of thoracoabdominal NRP, while the pressure in the abdominal cavity increased once thoracoabdominal NRP is started, and the pressure in the thoracic cavity is increased, the pressure in the circuit of Willis remains static with no pulsatility at all during the whole procedure. Now we have gone further, and we are assessing the pressure in the circuit of Willis and the pressure in the basilar artery. So we have the whole circulation, and there is no change a lot. So we think that maybe there is thoracical perfusion throughout the head, but the brain. But if we clamp the supraortic vessels and we section them, and the cephalic ends are bended to the atmosphere, I think there is no real perfusion to the brain. And we have real evidence just from the very beginning that the pressure in the whole circulation, brain circulation, is the same that we have when there is cardiac arrest during the 5 minutes or non-touch period. I think, Antonio, tell me if you agree or not, that this is the most important problem that we have faced, the ethical problem we face today worldwide, and this is probably the main barrier to spread the use of thoracoabdominal NRP worldwide.
Definitely, I think that this is exactly the point, and I can see as well. I think there is a lot of questions. I don't know whether actually we can also answer this offline if there is a way to reach the delegates, because there are a lot of interesting ones. Like one on the ethics that was about why we don't extend the no-touch period. I think it's been seen that the no-touch period goes from don't talk to the Italians to extend anymore, probably. But apart everything, like in UK, we have the 5 minutes, and most of the countries have 5 minutes. And there is a great paper from the Canadian group, which has showed that 4 minutes and 20 is possibly the safest time. There will be no spontaneous reversible activity after that. And 5 minutes sounds just right. But this comes also from the background of all the cases that all the DCD which we have performed in UK, in Spain, there have been no single case of spontaneous activity, again, return to spontaneous activity. So I think these are all challenging as well, and is clearly we don't have a 100% answer on this, but we need to get there. We need to get closer to that as much as possible with that.
There are several questions about the use of sedation after the withdrawal life-sustaining therapy. And I would like to emphasize that I'm an intensivist. In all intensivists, in all ICUs worldwide, the main cause of death is the withdrawal life-sustaining therapy. Even though most of these cases, they are not donors because they don't have the possibility to donate because they are with multi-organ failure or whatsoever. We are using sedative drugs for all patients in which withdrawal life-sustaining therapy is performed to the best of patient interest. We have to sedate these patients, no matter if they are donors or not. It doesn't matter if they are going to become a real donors or not. We have to sedate them for the reason that is better for them. As it depends on your legal framework, but in Spain, our idea is that we have to sedate those patients in which withdrawal life-sustaining therapy is performed, no matter if they are organ donors or they are not organ donors. That's my point of view. I don't know, Velia or Constantino or Marius or Antonio, if you have other explanation to that.
I think, if I might, yes, definitely. I think we need in this, the end of life care we provide in a way doesn't need to be biased by the donation process and retrieval process at all. And we need to make sure, because up to the point of declaration of death, what we are looking after is our patient and their family. And clearly, we are always like working in a transplant center. We have seen patients on acute heart failure dying waiting for a heart transplant or for our organ. Clearly, we are biasing and say we clearly need to do the most of it. But looking things from the other side as well, I think we see families which they go through very stressing time of their life, which might leave trauma for a long time. Clearly. So I think we need to balance the two things clearly. And I think the best way, or in a way, the way is probably to try to think that we don't need to think of that outcome in that perspective while we are looking after our patients. So yes, we should do, as you said, the best for the comfort of our patient, for their family, regardless to whether the process is going for donation or not. So this is to provide the best end of life care.
Okay.
We administer analgesia and sedation eventually to prevent any kind of pain, any kind of discomfort in the donor. This is not only legally admitted, but it's also mandatory because you need to prevent any kind of suffering, even if you have a shorter time from withdrawal of life-sustaining treatment to death because of this analgesia and sedation, but it's mandatory. We do not want our donor to suffer.
Yeah, I think from surgeon's perspective, even in UK, we see a large variation in practices, and I know that there are large variation among countries, but wherever we attend, I think the gold rule for surgeons, particularly for the retrieval team themselves, not to get involved into this aspect of the organ donation, because that always raises question, potentially we might be considered biased. So that's why for the surgical colleagues, I always suggest just follow the local policy, and whatever they would like to do, we just follow that.
Yeah. There is a question for you, Constantino. There is what are the long-term outcomes of uncontrolled DCD livers compared to controlled DCD livers?
Where the outcomes are slightly inferior in terms of graft survival. Basically, the need of transplantation due to ischemic type biliary lesions are higher because, and this is understandable because the warm ischemia time is much longer in the uncontrolled situation. And now the controlled DCD liver transplant outcomes are similar or even better, as I showed you, than the regular livers from DBDs. According to the experience of the Netherlands, 7% of ITBL versus 2, 3, 5% in controlled DCDs with abdominal NRP. So based on that, obviously, uncontrolled DCDs outcomes are inferior. 5 years, maybe in our experience, 1 to 5 years, the graft survival was 70% versus higher than 90% in controlled DCD, so less than 20% lower. And the loss of the graft losses were mainly in the first year, between 6 and 12 months, which is the timing when ITBL shows clinically the impact in terms of the situation of the graft and the patient, 6 to 12 months. So from 1 to 5 years, the similar graft survival, 70%.
If I may, in Spain, we have decreased so much our figures in uncontrolled DCD donation.
Yes.
But the reality is that we are more strict. We are stricter in our admission criteria, and we have had very good results with kidney donation. The reality is that in those uncontrolled DCD donors, the kidney survival is excellent, similar to those obtained from DVDs. In livers, maybe the liver is more sensible to the ischemia.
Yeah, this is a good point. We don't just need to think about the liver, but the kidneys. I think the uncontrolled DCD are an important source of kidneys for transplant, for sure. I'm convinced.
And just to refer, someone asked about setting up a DCD program from donation perspective or from retrieval perspective. There are numerous steps, probably beyond the time of this, but for uncontrolled, it's even more challenging. You need a lot of enthusiasts, a lot of, I see that, yeah, I fully agree. And a lot of availability, a lot of effort to make it happen and to be available. So it's not an easy task to achieve and sustain an uncontrolled program.
There is a question about if uncontrolled DCD donation should be assisted with ex vivo perfusion. In my experience, I don't have experience in liver transplantation. I have experience in lung and kidney transplantation with uncontrolled DCD donors. In our case, we always assess lungs and kidneys in ex situ devices. In all cases, we have performed more than nearly 100 kidney transplants with uncontrolled DCD donors. In all cases, we assess the kidneys with ex situ devices to be sure that the prolonged ischemia has not damaged irreversible the kidneys. And we do the same with the lungs obtained from uncontrolled DCD donors.
Yeah.
Yeah, same situation for the liver. Yeah.
I have a question from Suresh. Percentage of successful lung retrieval to transplant after TNRP, ANRP. I'd like to refer you, there's an excellent paper earlier this year from the French group. The main author is Eduardo. So they published their data with 80 lung transplants with abdominal NRP. The French protocol and setup is that all DCD donors will have ANRP, and all lung DCD will have EVLP assessment. Their conversion from EVLP to transplants is over 80% with fantastic first year and 5 years results. We have a limited number in UK, which is more challenging, the setup. There is loss of organs, but those were retrieved. There were 15 lungs with NRP, and the PGD and 99 survival were equal to DBD. For the TNRP UK data, there were only 3. They were all alive. They were from the 25 they were done. And again, refer back to that paper from Cedar Sinai, which summarizes US data. Those who were retrieved, they did very well. But again, these were selected younger donors and so on. So definitely we need more data regarding TNRP and lungs.
In our case, we published last year in American Journal of Transplantation our single experience in our center with 60 lung transplants obtained simultaneously with abdominal NRP. The 5-year survival was 69%, similar data than the international registry. And I have to say that the median donor age was nearly 60 years. So with no ideal donors, we obtained excellent results. In the case of thoracoabdominal NRP, we have performed 3 cases. And I have to say that all cases were excellent, but the reality is that at this moment, our thoracoabdominal NRP donors are excellent, are younger than 45 years. So we are very selective up to now in the case of thoracoabdominal NRP. But I think the initial experience have been excellent.
Yes,
may I ask something, Eduardo? Because we talk about adult patient, adult donors. You talk about younger donors, but you also published recent this year an experience with 13 children on NRP. About the technical perspective, how small was the smallest patient, the smallest donor? And do you have some tips on cannulation and aortic occlusion in smaller children?
Yeah. We published the Spanish experience with 13 cases. In my center, we obtained 5 cases. from 3 days up to 70 years. In the case of kids over 40 kilograms, the cannulation is identical to the adults. I mean, if they are over 40 kilograms, we perform premortem cannulation. In all kids below 40 kilograms, the premortem cannulation is impossible. So we perform postmortem central cannulation. That is much better. We cannot perform peripheral cannulation in kidneys below 40 kilograms. The results were spectacular. We obtained 11 livers, all the kidneys. We also transplant 4 cases of lungs and two hearts. And the results, I mean, we have only a follow-up of 1 year, were ideal. I think the main difference in the case of kids is that we have to perform postmortem cannulation, postmortem central cannulation in those kids below 40 kilograms. Last year, we performed in Spain, in my center, the first neonatal heart donation. 1 kit of 3 days was obtained in my center. We transferred this heart with postmortem central cannulation to Madrid. It was transplanted there. And I think with these devices, with the ECMO, we have a lot of possibilities to use any kind of donors, from 3 days newborn donor up to 60, 70, 75 years old. I think these devices provide excellent results. They increase the organ rate utilization, and it provides excellent recipient survival in my point of view.
Yeah, can I just add, I mean, yeah, sorry, Marta, yeah?
We went up to 86 in the region.
86.
In our region, 86.
Amazing.
Successful with liver.
It's a fantastic topic, the pediatric, and again, NRP for the heart, focusing on the heart for DCDs. The only commercial available device, the cutoff is 50 kilogram and above. So the only way to utilize DCD hearts at present is TANRP for DCD hearts. So that was a fantastic paper and fantastic result, Eduardo.
Thank you. I think the message of the kids is that we can do it. I mean, most of our Spanish teams were reluctant to use kidneys from pediatrics because the results initially, it seems worse than DVDs because of the size of the vessels. But with ECMO devices, I think we can assess liver function or kidney function, and we can go further because it's necessary this type of donors, for sure.
Yep.
Any other question?
I see a few questions from anonymous attendee. There are a few questions about DCDs. I think there are some fundamental questions that maybe we'll take. We're already slightly beyond. So very happy if you'd like to contact us and then how to set up the DCD, the NRP for the DCD hearts, how to declare. I don't think that there's any setup to declare organ donation after cardiac surgery. I think we always go to cardiac surgery hoping that they will come from there alive. So I don't think we have a process to discuss organ donation with any of our patients going for elective or urgent cardiac surgery. That's a process that will follow, never in theater immediately after the cardiac surgery. It will follow after patient comes out from theater for potential organ donation. Any other point?
Well, Marius, I think maybe it's time for end this webinar.
Yeah, okay.
We have been set to finish in 1 hour. We have spent 90 minutes, but I think it has been a lot of energy, a lot of questions. And in my personal point of view, I would like to thank the attendees and the speakers for the excellent lectures, for sure.
And thank you very much, EuroELSO, for setting this up. Hopefully, first of many.
Thank you.
Thank you.
Thanks all of you. Bye.
Thank you.
Thank
Pleasure.
you.